Welcome to everybody to our presentation about breastfeeding. This is one of our final webinars. We have two more before the end of the month, before the COE has to step away from its role. So this is Dozier, and I'm here today with Dr. Rosen-Carole, who's the Medical Director of Lactation Services and Programs here at the University of Rochester, and is also an Assistant Professor of Peds and OBGYN. Here. We're going to be changing a little bit about how we do the webinar. We're going to do some questions and discussion first because Dr. Rosen-Carole is not, it can only be with us for a brief period of time. So she runs our lactation services here, so brings a lot of good clinical expertise working with our populations. So our first, just to let you know what we're going to talk about is generally the current state of breastfeeding, how to talk to women who are pregnant about breastfeeding, some anticipatory guidance, and managing in that early time post-discharge in the hospital and how to sustain it. But the first thing we want to know is who's participating on the call. So we have a poll, two polls that they're very quick answers. One is that we're trying to get a sense of, what program are you from? Are you from a MITCH, a Healthy Families New York, and an NFP program? And then the second question is going to be whether you're CLC trained. So it's kind of a yes, no. But I know sometimes when people log in, you're logging in with one phone, but there are 2 or 3 people around the table. So if you're a group to respond to the CLC training, if it's a group that's listening, the question is, are most or all of you CLC trained? Or if you're a group listening and few or none of you are CLC trained. So we're going to pop open the poll
Perfect. So just make sure that you answer both questions and then hit submit so that it transfers the information over to us. And we'll give you just a couple more seconds here.
Almost not.
All right, we'll go ahead and end that poll.
And if you want to just verbally, I'm a little distant from the screen where the poll results are, so I'm going to let Pam speak to what the poll results are.
We have about 16 MITCH people online. Then we have, it looks like 3 with McV, 2 NFP and 1 Healthy Families. And then there's 2 people that are other. And then as far as the training, it looks like 57%, so 12 people are not CLC trained. 6 people are CLC trained. And then with the groups that are listening, few or none are CLC trained.
Okay. Great. Well, that just gives us a sense of who's in the audience. So I'm going to skip forward several slides here to a list of common concerns, and you're going to get to do another little vote here. We will come back to these slides. So let me just explain to you what we're going to do for the next little bit. We want to get a sense of what are some of the questions or problems that you have. This list was actually modified based on some feedback from a pre-webinar survey we did about 10 days ago. So we're going to want you to vote on these, and then we're going to go to the list of scenarios that were identified also through that poll. And I'm going to ask Dr. Rosen-Carole to kind of talk about her approach with those, and then come back to these common concerns piece. For those of you who may or may, so a nursing strike is when you have a breastfeeding baby who essentially decides he's going on strike. It's not that the kid hits the mother. I mean, I looked at this going, I can't, it's an interesting terminology we put together. And then if you click other, you can put some detail in through the chat mechanism here if you want to provide that. So we're going to open up the poll. Let us know. You can obviously check more than one. And we'll wait for a minute or two to see what people have identified as those. half a minute if you can check your interested or your common concerns of mothers and what you have run into, and what do you have questions about? You think we're pretty good yet?
We'll give you about another 5 seconds. So just go ahead and make your final choices and hit submit. Okay. Here are the results.
So I'm going to have Pam voice over the results for us. Oh, I'm sorry, she's delegating that task to me. Okay, so 38% responded of sore nipples, about 67% had with the maternal perception of low milk supply, about 48% had actual low milk supply, 29% engorgement, 48% nursing stripe, plug duct or mastitis, another 29%, and then we had 20% had some other comments. So we're gonna go to the next slide, and then we're gonna come back to this list because I want to respect the people who identified issues through the pre-survey, and I think we got 8 or 10 different responses. So these are some either exact quotes or an interpretation of what people were saying and blended with a couple comments. So I'm going to turn this over to Dr. Rosen-Carole to talk about some of her approaches for these.
Awesome. Thank you so much. I'm so glad to be here talking to all of you. And I also see that some of you are putting some things in the chat box that I hope that we'll have time to get to. And if we don't, then I can always respond by email.
Yes.
And we can send it out to the group that way.
Yeah, thank you.
So the first scenario, I think, if we had a hand raising, I think most of you would probably raise your hands that you've seen a case like this before, with or without the tongue tie. Oh, these are all different
These are
scenarios.
all different.
Sorry.
Sorry.
So, you've probably all seen all of them before. And I think what's particularly interesting about the first one is it's on day 4, so we can talk about what that means. But first, let me talk a little bit about my general approach to breastfeeding issues from a medical perspective. And I'd say the first thing that needs assessment that I'm sure you're all pretty good at, whether or not you've been trained as a certified lactation counselor or, have training in home visiting, is assessing the emotional cloud around what's happening. Because I find that the emotional cloud is very informative, meaning who is worried, how much are they worried, what are they worried about, and who's around them worrying, and who is in their community worrying or supporting them. And I think that once you do that assessment, which you've all had probably extensive training in on a variety of topics, you can use that information to assess the breastfeeding problem as well. So for instance, mother is on day 4 and milk has not come in yet and baby seems hungry. You might see a dyad like this, dyad meaning mom and baby, where the mom is not the one who's worried, right? It might be the partner or father who's worried. It might be the grandmother who lives in the home who is worried. It might be friends or family that have no experience with breastfeeding. So getting at the background for that is really important. My next step is really getting a sense of where the problem seems to exist, right? And so then I tend to think of breastfeeding problems as having 3 components, right? Because it's dyadic, it's always 2 patients. So there's going to be issues on the side of the mom, issues on the side of the baby, and issues with the interface. And every time I think about a breastfeeding issue, I try to picture which one of these issues is coming first, because an issue in any of those can affect everybody downstream. But it helps me to stay organized. And then the third general principle that I'd like to bring up is what other providers have been involved and what other information are people getting? So for instance, have they seen a pediatrician? Have they seen a lactation counselor consultant? who else has given them advice, and what that advice was. One of the things that we hear most often from women is that they're really tired of getting conflicting advice. And we need to be really careful how we phrase things. And we can't be careful how we phrase things if we don't know what they've been told before. So making sure that we have a sense of those three things. One is the emotional cloud. Who's worried? What are they actually worried about? The second is trying to figure out which level is the problem. And the third, asking and assessing what they've heard before, where they have gotten their information from. And this might even include things like the internet, blogs, right? Facebook, like where have they been exposed to advice that they may or may not be following? So getting to the cases, the first scenario is mom is on day 4, milk has not come in yet, and baby seems hungry. Now, the largest disservice we could do here to this mom is to say, oh, yeah, everything's fine. Breastfeeding always works. Now, let me show you how to latch and send her on her way. The first step that we really need to figure out here is she right? Is this a maternal perception of low supply, or is this maybe delayed onset of milk coming in? We call that lactogenesis too, and a real problem with milk supply. And being home visiting nurses and staffing, one of the things many of you will be comfortable with is how to assess whether a baby is okay or not, right? Or knowing how to refer to somebody who can assess that. So I'd say your first step on this case is to make sure that the baby is okay. So you could check a weight, right? And if that weight is well below birth weight, by day 4, we're looking in the 5 to 10% range, then we might be worried, right? The other thing we might check for is, is the baby really crying in hunger? Does the baby seem really hungry? Does the baby have dry lips? Is the baby peeing and pooping? These are all regular baby dehydration assessment that may or may not have anything to do with breastfeeding. It's just assessing the infant. Or if you can't do that yourself, making sure this mother gets somewhere to assess the infant, because that's going to take you on a very different path. So the other side of it is assessing the mom to make sure that she is otherwise okay. Does she have a history of things that get in the way of milk production? You don't have to remember these lists, but just keeping in mind that mothers who have high-risk deliveries of a variety of kinds can have trouble with that onset of milk, right? So once you figure out whether there is really a problem here, you can figure out what to do. So let's say there really is a problem. Let's say the baby really isn't peeing and pooping, and the baby really has lost a whole bunch of weight, and the baby really seems hungry to you, right? First step would be to get this baby to a pediatric provider same day, because pediatric providers are required to see babies same day if there is a medical concern or emergency, and make sure the baby's okay. Because our priority, if the baby is dehydrated, is to feed the baby, right? And that could mean pumping and feeding the baby by a cup or a bottle or some other mechanism, or it could mean formula if the mom can't get milk out with her hands or her pump. But I think your priority would be getting this baby to an assessment, a medical assessment. If you identify high risks on the side of the mom, getting the mom immediately in for assessment would be important as well. Not enough detail for the high risk. There's a lot, there's always a lot more to talk about in terms of high risk, but I want to make sure to cover all the cases as well. I think what you'll see more commonly, and probably you're all shaking your heads saying, that's not what I see. Because probably what everyone sees more commonly is the perception of low milk supply, right? Because day 4 is, maybe a little bit late for that second milk to come in. But it's, for a first-time mom who doesn't necessarily know what to watch for, or if she has obesity or very large breasts, it might feel very different to her. And we need to find out why baby seems hungry. So again, step 1, who is concerned? Is mom concerned? Is grandma concerned? Is dad concerned, right? Mm-hmm. Dealing with the emotions, the other things going on, right? Is she really worried about this, or is there something else happening?
And what is she assessing to make her draw the conclusion that the baby seems hungry?
Absolutely. And then clinical signs of the baby, like why does she think that the baby seems hungry? You might look at the baby and not feel like the baby seems hungry. So giving her that sense. One of the things that we see commonly is the self-fulfilling prophecy of having given a bottle and having your baby pass out. So what happens is
Pass out
means go to sleep.
Yeah.
Sorry. What we find is when people feed a bottle, the newborn bottles of Enfamil tend to be 2 ounces. We all have seen the baby bellies, which are the stomach sizes, showing that a baby on day 4 will have a stomach about the size of a ping pong ball, which is not 2 ounces large. It's 15 to 30 cc's. Which is about a half an ounce to an ounce. So if that parent is worried that the baby is hungry and wants to give a bottle goes down very quickly. They tend to overeat, and then they tend to oversleep. So it's a self-fulfilling prophecy where the family feels like, therefore, they have diagnosed that the baby was hungry. And I liken this to lots of other things that we do in medicine. For instance, college students who take ADHD meds who don't have ADHD in order to pass an exam. Did it help them focus? Maybe. Does it mean they have ADHD? No, right? So just because it works doesn't mean that that was the cause. That wasn't the initial problem. So sometimes helping people to understand that rather than that being the solution to a problem, that's actually more like us eating a Thanksgiving dinner and falling asleep. Is it a good sleep, or is it an uncomfortable, overfull kind of sleep? And is that why we oversleep and end up coming to work late the next day? It also helps to remind them that the mechanics of eating are very different on a bottle than on the breast. And it comes out much, much faster. And that can get in the way not only of their baby nursing, because if you feed a bottle, remember, you're going to miss the one nursing where you would otherwise have breastfed, and then the baby will oversleep. The baby will sleep 3 to 4 hours instead of the more normal 1 to 2, and now you've missed 2 or 3 feedings. So reminding them that doing that is not benign.
Right,
one of my favorite...
It's a supply-demand process, so
right.
You're in that transition in this day 4 to making certain that to create the milk, you've got to have the baby suckle.
Right, and that's a really important point, is that by day 4, milk production is entirely dependent on getting milk out, right? So it's hormonally controlled for, the beginning, but after that, it really needs to be taken out in order to be made. And women make all sorts of increased cells in their breast. They get more branching in all of their ducts. They make more milk if they get more emptying and more stimulation. So one of my favorite models for helping with maternal perception is, I heard this one lactation consultant say it this way. If you put your favorite color of tape around that baby bottle, right, and you taped it up so you could never ever see what was inside that bottle, how would you know that your baby was full? And if you ask that question to parents, they can very often come up with a lot of good answers. Even new parents, they'll say, well, my baby got sleepy. Their arm got droopy. Their eyes got droopy. They stopped sucking quite so vigorously, right? It's helping them to be less connected to the ounceage and more connected to looking at the baby, which is essentially teaching them to read baby cues, right? And so that is one of the other things that can really help with perception of low supply, particularly at this moment. The other thing is definitely always referring to the pediatric provider, whether that's a family medicine or a pediatrician, who can say to the family, look, the baby's weight is fine. I think you can they're peeing and pooping. I think you can give this another day. And if you can couple those two, and if you're an RN and doing home visiting, if you can say that, then that's great. And close follow-up, because they're going to need the reassurance. And so are you, because if by day 5 this baby is not peeing and pooping, even if you thought it was a maternal perception, it could turn into a problem. And we don't want to do the family the disservice of missing a problem if there is one. Anything else to add, Anne, on that first topic?
And I think we actually touched on the third one as well. Interpreting
infant crying as being hungry. Yes. And then the other thing about infant crying, just to tie that loose end, is, teaching other ways of soothing, right? Feeding is a very convenient way of soothing. Eating a Thanksgiving dinner is a great way of making me go to sleep. But there are other things that can relax me that might take more time or more education, right? I could learn to meditate. You could learn to swing your baby or shush them. So there are some acronyms that we use in pediatrics, like the 5 S's, which is swing, swaddle, shush, suck, and never ever shake, right? And just reminding people that they can put the baby down and walk away is really important, because this baby might be showing early signs of colic, right? And when we are frustrated, what do? Naturally, we shake our bodies, and we don't want to shake the babies. The other thing about infant crying, another interesting approach that I saw was a pacifier bag, where people, instead of giving pacifiers that could potentially get in the way of breastfeeding, they had a bag of a whole bunch of other ideas. And in there was the pacifier. So if a family wanted a pacifier, they got a pacifier and education and a swaddler and some ideas about shushing or bouncing or swinging with the baby or singing to the baby, all of these other things. And never underestimate the power of skin to skin. Now, one of the things that we find with infant crying is that sometimes babies do not soothe on their mother's chests with skin to skin, particularly if they're the kind of baby who can't figure out if they're hungry or not. And so don't forget the other partner, that skin to skin on the non-nutritive soother, meaning a soother in the family that's either the father or a partner or somebody in the family who can hold the baby but not smell like milk and give that baby that maddening cue that they think they're hungry but they're not. Is huge, and that's hugely supportive of the mother as well. Other thoughts on crying? Okay, so let's talk about tongue tie and problems latching, which are a little bit related, but also a little bit different. So why don't we start with the problems latching? So the problems latching, I think, most commonly occur in some deliveries where you have not necessarily received appropriate care for whatever reason. And it might not be breastfeeding supportive care because the baby had to be whisked away to the NICU, right? Which is a good thing because we have NICUs and babies live longer because of that, right? But it can also get in the way of breastfeeding if you have infant separation. Or maybe it wasn't for such a great reason. Maybe in your facility, the anesthesiologists don't let babies do skin to skin in a routine C-section. Or maybe babies are not getting skin to skin after birth with regular vaginal deliveries. If these are the case, or if you see routine supplementation in the hospital for, non-medical reasons, or if you see pacifier use for, overuse in your hospital, things like that, then a conversation with the local hospital is going to be really important. And that can happen through local collaboratives. It can happen one-on-one. It can happen with breastfeeding champions. But I do often see women who have been discharged who have never latched. And, the question is what do you do with that? So again, assessing the emotional cloud. Is this a mom who is saying she wants to breastfeed, but for some reason can't get that baby onto her breast? And this is particularly reminiscent of a mother who has a history of trauma or abuse. We know little about this population except that we all see it anecdotally, mothers who say, I want to breastfeed, but I can't have the baby at my breast, and are unwilling to say more. And it makes sense to have our ears tuned to this possibility so that we don't overemphasize or make women uncomfortable if this is part of their problem. And we can ask gentle questions about it. Does it feel strange to have your baby at your breast? Can you explain more? Has something happened to your breasts before? Or, those kinds of things. And sometimes women can pinpoint it and sometimes they can't. Second part of the general approach, is this a mom issue, a baby issue, or just a latch issue, right? So it could be a mom issue, meaning if she doesn't have milk, the babies might not want to latch, right? And so she needs to be cared for and see her provider. It could be a baby issue where the baby has a tongue tie or a posterior cleft palate that was missed, or suck dysfunction. For instance, this happens a lot in the premature or late preterm population. So really assessing the baby for what could be going on. Or is this a latch issue, meaning just the interface? And the most common reason I see that is really malpositioning. that people put their hands on the back of the head and try to shove the nipple into the baby's mouth when the baby's screaming. And for some reason, even though that mouth is open wide, babies never latch when they're screaming unless they're, 4 months old and, crying because they bumped their nose. So finding out what is the issue. Now, if the issue is positioning, then talking to your lactation counselors. There's a few resources that you can learn on how to help babies latch, and maybe we could send those out by email. There's a really nice video through Stanford. It's a 15-minute counseling video that's made by Jane Morton, who is widely recognized to be a leader in this field. And you can just Google 15-minute breastfeeding counseling video Stanford, and that will come up. And that can help you with the mechanics of actually getting the latch. Tongue tie is kind of a larger beast and remains controversial in many communities. I have a Grand Rounds presentation to this. If you Google the University of Rochester Pediatric Grand Rounds.
And we'll send out these details.
They'll send out the links. And it is a videotape presentation with myself and a local ENT, Margot Benoit, talking about the ins and outs of tongue ties. And it's a very medical, evidence-based presentation. So if there are disagreements in your communities about tongue ties, this is a place that you can use as a reference. Briefly, my take on tongue ties is that they are about 1 in 10 babies, it seems, and about 50% of the time they cause trouble with breastfeeding, which means not all will, and that it's much more about the function and movement of the tongue than it is about how the tongue tie looks. And this seems pretty clear based on the data we have. If a tongue tie is identified, even the American Academy of Pediatrics states that it should be taken care of sooner rather than later. And we do find that first-time moms have a harder time assessing whether tongue tie is the issue as opposed to second or third-time moms. So if you have a baby and the baby has a tongue tie and mom has
the mother says the baby has
and the mother says the baby has a tongue tie, or you can check for it, or a pediatrician or lactation consultant has said so, and she's a first-time mom, you might do some lactation work first and see if it improves. If she's a second or third-time breastfeeding mom, I would more readily get her to somebody who can assess and take care of that tongue tie. And warning people, I always warn my patients that there's disagreements, and what I say about tongue tie might be a different interpretation of the data than what they hear from their pediatrician or their OB or their lactation consultant. And so it's important, again, we don't want to split these women between providers. We want to support them and give consistent evidence. And it helps for them to know that, this is my interpretation of the data. This is what I see. Somebody else might say something different, but it helps to have people in your community who you can partner with to make sure that you're saying the same thing. So again, this requires a little bit of outreach, talking to the pediatricians, maybe even calling the family medicine doc or the patient's pediatrician and saying, hey, I'm worried about this. What do you think? And starting those conversations, referring them to our Grand Rounds presentation so that you can develop a little bit more of community consistency so that women don't just get fed up and throw up their hands. Anything else on tongue tie?
No, I think
No.
keep it going.
Okay.
Not in respect of your time.
Sure.
Nursing strike.
There's also in the PowerPoint, the posterior tongue tie beast. Again, I use that word again because, these are all of my very special migraine triggers. There's a little bit in the Grand Rounds about that. So if you do want to hear more about posterior tongue tie, feel free to check out the Grand Rounds. So nursing strike. So nursing strikes, in my experience, happen in 2 ways. First of all, they tend to happen with older babies, and older, I mean, they don't tend to happen in the first few weeks of life. If you hear from a mother that the baby has a nursing strike in the first few weeks of life, be really worried and get her to care very quickly, because this is not something that tends to happen that early. It tends to happen, honestly, more around teething. And the thought being that maybe the babies are achy right? And teething behavior and achiness starts well before teeth come out. So teething behavior and achiness can start between 3 and 4 months of age, even though you might not see your first tooth until a year. And so these are babies. It happens in 2 ways. One is the baby has always been on a bottle to some extent, and then starts preferring the bottle. And the other way is the baby has never had a bottle and just stops eating. Now, there's some really good patient-centered advice on this on the Kelly Mom blog that's written by the lactation consultant. So I tend to use that to give out the parents' advice. In general, if the baby has never had a bottle before, I would not at this point introduce a bottle. You can introduce a cup. You want to make breastfeeding a safe, warm, happy place. If the baby should be assessed to see if they're sick. Maybe they have a sore throat. Maybe they have a fever. Maybe they have an ear infection. I saw a nursing strike once when a baby had an ear infection because it hurt to move the jaw. So assessing the baby, making sure the baby is safe, then making sure that the mom is okay, and lots of emotional support to get through it. There are some other ideas like distracting the baby to get the baby to eat, or, lots of skin-to-skin time and snuggling the baby. Definitely if the baby cries, take them off of the chest, and making sure that the baby stays hydrated. The other is if the baby has always had a few bottles and all of a sudden becomes committed to the bottle. And this may or may not be a nursing strike. This might be more about mom's milk supply or baby's tongue mechanics. And so it makes sense for this family to see somebody with advanced knowledge in breastfeeding. You can work on it the same way as the first nursing strike instance, where distraction, support, hydrating the baby, lots of snuggle time, or you can assess and just see if there's something else going on. So I've seen that happen too, particularly with the babies with suck dysfunction. And then finally, how to encourage and support breastfeeding when family members encourage bottle feeding or discourage breastfeeding. And I think if I had the answer to this, I would feel like my career could be over. Unfortunately, this is really tricky, and it needs to be different for everyone. So this kind of also goes with the thing that we saw, the chat that came in about discomfort about bodies doing this. It encompasses privacy and safety concerns, and it depends a lot on the particular mom. And also we hear things like it's too much work or it's inconvenient. So what I like to go back to with respect to this is more of a motivational interviewing approach, the same way that you're taught for weight loss, smoking cessation, other things. I try to identify what is the mom's goal and where did that come from? Tell me why you want to breastfeed. Tell me why your goal is that. How did you make that decision? Good for you in making that decision. And then identifying other places in life where she was able to succeed at something and what was required for her to succeed at that. Have you ever overcome the resistance of your family members for something you felt like you wanted, for something you felt was right? And when you identify that little kernel of truth that is the reason women are choosing this, it can be much easier to then help them with good answers for when their family members are sneaking away the baby in the corner with some formula and supplementing behind mom's back or discouraging her from breastfeeding. Some of the thing around the discomfort, for teenagers, particularly I see this, or women who leak a lot, or women who have a history of abuse, I try to connect with more of the social, right? More of the emotional reasons for breastfeeding, the magic of breastfeeding, that it changes by day, it changes by time of day. It's different from your baby than the breast milk is from your friend's baby. And just really connecting to some more of those emotional reasons as opposed to, focusing on the downsides. It is a lot of work, but women put in a lot of work for a lot of things in this world. And most of the things people choose to work for, they think they're worth it. And so how can we help them connect with that truth? So I think I've made it through the list.
Do you have any comments or resources about these couple of other things that were a little lower on there, like either the sore knuckles
Sure.
or the, and engorgement or anything?
Sure. So we have sore nipples and engorgement. And I'd say sore nipples we're working off of for most of the time. It really is about a symmetric latch. And so getting them to a lactation counselor, getting that baby nipple to nose, teaching them how to line up the baby straight is hugely important. But let's not forget that sore nipples also come with tongue tie and suck dysfunction. And so making sure the baby is evaluated for that. The other thing is if you feel like there's a tongue tie, but you can't be the one to assess it, sometimes laid back positioning with the baby on top can be a much more comfortable position. For engorgement, the best thing is bra support and lots of breastfeeding. But there's also a beautiful video on a lymphatic drainage massage that I find works for engorgement, for pending mastitis, for lots of things. And you can find it at, it's available online at bfmedneo.com. It's a lactation consultant and a physician pair that have actually studied this and find that their technique for lymphatic drainage massage, when done about 20 minutes a couple times a day, improves engorgement quite a bit, decreases mastitis, decreases the risk of antibiotics, and it decreases pain. Then there are the other classic tricks for engorgement. Again, Kelly Mom is a great resource. So cool compresses, soaking in baths, reverse pressure compressions to make sure that the baby can get the nipple into the mouth, a little bit of pumping, not too much pumping, or hand expression to help get the milk out. You don't need mechanical things to help you breastfeed if you've got your hands and your baby. So
I think those were the main ones.
Great.
And I know we're kind of at your time. I appreciate
thank you.
that. And I will, if the folk on the call, you have specific questions you'd like to direct to Dr. Rosen-Carole, if you put them in the chat box or email them to our MIHCOE email, we will compile those and get some generic answers out. I feel like Casey's a rather hard act to follow here. I will do my best, and we're just going to go back to the beginning. And I hope that was useful. I would have loved to have had her here the whole time. So we're going to just pop back to kind of where things are relative to breastfeeding, and some of this is just a bit of regrounding in kind of why do we care, so the notion is that human milk is species specific, and anything that is essentially man-made, whereas a substitute for that are quite different from human milk. And it's interesting because we call it breast milk, but we really should call it human milk, because that's what we do for all the other mammals. We call it goat's milk and we call it cow's milk. We don't call it udder milk, for example. And we toss around a lot of terms, and I think those of you who interact with mothers in the prenatal period, we're really looking for them to establish an intention to breastfeed, and then we look at did they actually initiate? So did the baby actually get anything? So that's usually what happens in the hospital. And then when we talk about exclusive breastfeeding, it means that they haven't gotten to date in their life, whenever that's being assessed, they haven't gotten anything other than breast milk from the time of birth. It may have been a few vitamins, but no water, no formula, etc. And then full, predominant, or complete breast milk feeding means that is a definition that's applied when so a mother is now at 2 weeks or at 4 weeks or at 6 weeks. It's all of the feedings, or nearly all of the feedings, are from breast milk. And then you can see there's partial feeding and no breast milk. And while we used to, interestingly, focus on women supplementing their breast milk with formula, what's interesting is that we're starting to find that some women who breastfeed don't when they want to give their child something else, they don't switch to formula. They may stay breastfeeding, but they're starting to introduce complementary food or juices well before 3 months. So while the baby may be not getting any formula and still breastfeeding, they may be getting food or juice and breastfeeding. And so they're no longer exclusive breastfeeding. As soon as you introduce anything outside of the regular, outside of breast milk, then you're no longer exclusively breastfeeding. And the problem with doing that is that the infant isn't getting calories from the breast milk, which really has the right balance of nutrients. So I just point that out to you because we're seeing this not only within the research that I'm doing, but nationally, that there's this early introduction of complementary food that's quite worrisome. And just to point out, and I think I may have it later in a note, that the introduction of juice is now recommended by the AAP to not happen until after 12 months of life. It used to be the recommendation was 6 months. So my idea is that, well, mothers may have said, oh, well, he's only 2 or 3 months. I can give it to him at 6. I'll start it now. Well, now that window is supposed to be out to a year, there may be greater hesitancy to say, oh, well, I shouldn't be giving him juice if they're not supposed to get it out to 12 months. So, while 12 months may seem, not the appropriate time window to be talking about this because you're talking about really young infants, in the mother's mind, it may be harder to violate that guidance if it's at 12 months as opposed to 6. So these are just some different, statistics. Many of you have likely seen these. There's the Healthy People objectives for some key milestones relative to breastfeeding in terms of duration and exclusivity. I put up also some numbers for where the U.S. is and where New York State is. And then in another slide, I have some more focused numbers. But they've also, importantly, are now also looking at formula supplementation in the hospital, and that happens within the first 24 hours, as well as work sites, as well as births at breastfeeding supportive facilities, and that means that it's a baby-friendly hospital. So the rates are generally on the increase across initiation and the duration at 6 and 12 months. Exclusivity has not been, it's increasing, but at a much slower pace, and disparities persist with mothers who have lower education or lower income. They also, they have the lowest initiation, but they also have the lowest rates of sustained breastfeeding. In addition, Black mothers, and I know a number of you serve Black mothers, have lower rates, and that may be due to factors other than income and education. So some of the analyses will show that race has or culture, if you want to look at it that way, has an effect that's independent of income and education. Sometimes that's not the case. But in the Black-white disparities differences, poverty, college education, and marital status helped explain some of the differences in initiation. They also found that Black mothers weaned their infants about 10 weeks earlier than white mothers, and that white mothers were significantly less likely to get formula in the hospital than Black mothers. And that, again, is a big predictor of duration. And I realize you all don't necessarily visit people in the hospital. Some may, but I think one of the challenges we have, and that your organization or agency may have with working with the hospital, is what their approach is to introduction of formula in the hospital. And it's complicated by all means, because you've got a lot of different players, and you've got a lot of different you've got the pediatrician and the nursing staff, et cetera. There is an option that is being used by some places where they're, instead of, if the baby has a low blood sugar, for example, to give them a gel as opposed to giving them formula. And that seems to be cutting down the supplementation in the hospital. The other interesting thing about Black mothers is that they're less likely to have any kind of a family history of breastfeeding, and less likely to live with the baby's father. So having a family history of breastfeeding likely means you've actually seen somebody breastfeed, or you've actually heard somebody talk about it. So you have some sense of, this is something other people have done. And they're also, the less likely living with the baby's father may mean that there are fewer supports in the hospital. And just another couple of comments, that white mothers breastfeed nearly 7 weeks longer than even English-speaking Hispanic mothers. And the Hispanic mothers just tended to be a little younger and have a little less education. While on the positive side of it, they tend to have more of a family history of breastfeeding and more co-resident dads and marriage. And so that may be, while there is some disparity, it's not quite as dramatic for the Hispanic moms. Now, disparities can be reduced through coordinated efforts across the community, not just what you all are doing. And it obviously, could involve or should involve both prenatal and pediatric providers, hospitals, WIC, programs such as yours, as well as daycare providers and work sites. So that's some of the partnering that your organizations can do focused on breastfeeding to say, okay, we have a piece of the pie here, but there are other players who are influencing, and how can we coordinate our communication strategies and our approach so mothers are hearing the same information about breastfeeding. So here's some additional data specific to WIC. So you can see the ever breastfed and the breastfeeding duration at 6 and 12 months. So you got 80%, 40%, and then closer to 20% for WIC moms. Again, these numbers are on the improve, and they're a little better than the generic New York State data that I showed. And then the exclusive rates, you can see by 1 month, there's only a quarter or less than a quarter of moms are exclusively still breastfeeding, and that continues to fall off. Again, I think exclusive breastfeeding is the challenge. We are happy to have mothers do any breastfeeding, but it's clear that exclusive breastfeeding has significant benefits above and beyond just duration. So just as a point of clarification, so the current recommendations are exclusive breastfeeding for 6 months, with continued breastfeeding until at least the first year. And this recommendation comes from multiple different professional organizations. And mind you, not everybody can breastfeed. There's about 1% of women who actually can't breastfeed from an anatomical physiologic standpoint. But here, in terms of some of the other guidance in the US, anybody who has HIV or AIDS, has untreated active TB, for example, is using illicit drugs or is undergoing cancer treatment, like radiation therapy, etc., should not be breastfeeding. And then there's a small percentage of infants that have some metabolic disorders that they might not be able to breastfeed. That said, research continues to improve our understanding of the specific impacts of breastfeeding. So the brain development impact, so exclusively breastfed infants are more developed. Their brains are more developed than those babes who have been formula fed. And that's, interestingly enough, because human milk contains cholesterol. Now we hear about cholesterol, about how bad cholesterol is as adults, but when your brain is still under development, cholesterol is really important for the development of the brains, of their brains. And there is no cholesterol in formula, by the way. Just as another point, and this is something people have probably heard, but the breast milk does populate the infant's gut or digestive system with bacteria, and this is really considered a long-term impact. About 30% of the bacteria in a baby's intestine comes directly from the mother's milk, and actually there's a small percentage, about 10%, that actually comes from the mother's skin, interestingly enough, hence breastfeeding as opposed to bottle feeding of pumped milk, for example. That it helps digest the food and train the bacteria, help food digestion, and then they train the baby's immune system to recognize friendly and not so friendly bacteria, and in that way protect against allergy, asthma, and inflammatory bowel disease throughout their life. And as I said, the change of the bacteria in the gut difference between babies who are formula versus exclusively breastfed can be seen for years. And the other interesting piece related to obesity is that breastfed babies tend to be better protected against rapid weight gain, but only if formula or foods are not introduced earlier. And back to my point that many infants are getting something other than breast milk well before 4 months. Okay. So we walked through the common concerns and the scenarios, and I appreciated Dr. Rosen-Carole's 5 S's, the swing, swaddle, shush, suck, and don't shake. I think that's a very easy kind of acronym to remember. The next, I'm just going to walk through some points, and this has all been adapted from Your Guide to Breastfeeding, which is a guide for mothers and parents, available for free from the Office of Women's Health. It's not, they don't have electronic but not print versions there, but there's all kinds of great information in there, some very instructions about latch and about how to solve some different issues, and I think it's a great resource for you to have that you can then also share with your clients. So what we want to do is so why breastfeed? And so these are some of the things that have been said, that the milk changes as the baby grows, that formula is harder to digest, there's some disease protection, it's less of a hassle, less money, keeps the baby and mom close, it's good for health of the baby and the mother. And I'm just curious, which of these have you found to be most effective in kind of getting a mother interested in or maintaining her commitment to breastfeed? So, did any of these things, okay, I said that and that seemed to make a difference. I'm just curious about that. And then the second question was what some of you can put in the chat is there anything else you have found to be effective in either getting mothers on board with it, but just as importantly, keeping them and sustaining their commitment? Just curious here. So I'll give you a couple minutes or another minute to reply here. So I just want to give you another sense of, getting some more responses here. We'll leave it open for another few more seconds. Any last minute respondents here? And again, feel free in the chat box if there's anything else that you found that particularly resonates with your client. Okay, we're going to close the polling. Thank you all. So what we have here, they can see this, right?
Yep.
Okay. Is it looks like the big winner is the health argument, but other things, less of a hassle, so less costly, the maternal health argument, and then a couple things about fighting diseases and harder to digest. One of the interesting experiences that I had about the cost argument is, and this was about 5 or so years ago when we were working with a community council. So these were all kind of parents or family members, influencers of the mother relative to infant feeding. And when we showed them some ads as we were kind of trying to develop a marketing message, they didn't believe the cost ad because to them they could get formula anywhere. And so formula was essentially free. So anything that added cost, quote unquote, to breastfeeding was not, they didn't buy the cost argument. I'm not certain that is as strong a case now because formula isn't quite as readily available. Great, thank you. Okay, we're going to talk a little bit around some of the myths, and I'm just interested. We're going to do a poll. Which of these have you heard from your clients? So, kind of everybody uses formula. It's better. My breasts are going to sag. My breasts are too small. I'm not going to be able to make enough milk. It spoils the kid. It's painful. Just really interested in what you all have heard. And again, if you have a myth that you have experienced that's not on this list, feel free to put that in the chat box. We didn't get any additional comments from the prior poll. Mm-hmm. Mm-hmm. So in that we have can a client still breastfeed while pregnant? Well, the short answer is yes, but what's interesting is that the breast milk flavor changes, and I had a colleague whose baby essentially stopped breastfeeding, and she then found out she was pregnant, so the baby kind of knew ahead of time that there were some things that were different. And then a question is, have there been studies to support emotional well-being of mom or baby? I'm not certain. There's been more studies on the physiologic and health outcome benefits. I'm not 100% sure whether there's a lot that's been done about the emotional well-being, although mothers who breastfeed are less likely to get depressed and that. So there's some of that maybe in there. And then other question about, one of the other myths is that the babies children are breastfed for too long, and how can you really breastfeed? So what happens is eventually some of these kids, they're at the breast, but they're suckling and not generating any they're not getting any nutrition out of it. So it's more of a therapeutic, what we call non-nutritive sucking than it is. So you can breastfeed for years, technically, but at some point, what the child is getting is not really, it's not adding to their nutrition. It's more of it's more suckling in terms of its value. I'm not certain if I got to your answer. And one of my clients told me that her son was rejecting the breast milk because of the taste, but she was also told to stop by the medical provider. And it really depends on how the mother is. I mean, most women are not going to be remaining breastfeeding while they're pregnant. And we're going to close the poll. So the big winner was breastfeeding is painful. We'll come back to that in a minute. Hard to make milk. Breastfeeding creates saggy breasts, and then everyone uses formula. Okay. So let's talk just a little bit about, the breastfeeding is painful. And that is one of the things, I think that's one of the harder aspects to get to combat, other than to have stories from mothers for whom it isn't painful. And yes, and I think the other part of it is the first couple of times a baby latches on, it's going to be, it hurts, but it's like just a sharp hurt that goes away, and then you get used to it. And I think trying to, let mothers know that it's not like it's going to be that way for, forever. The other aspects are that sometimes it's painful because people aren't latching right. And so with the support that the mother is going to get, so if you're having this discussion prenatal, the support the mother is going to get is going to help her feel more comfortable that it is not going to be, that we can minimize any kinds of discomfort. So back to the issue of breastfeeding at 6 and 8-year-old children. So it's not even clear how much milk the child is actually getting with that. And yes, the quality of milk changes over time. And that's true even in the first few months, because the nutrients the baby requires change over time. And so yes, what they're going to be getting out of any kind of breastfeeding, even at year 1 or year 2, is going to be different than what the baby gets out of at 3 months. And it's because your body knows how long that baby has been, how old the baby is. It may sound kind of weird, but it's one of the neat aspects of breastfeeding. So I'm just going to continue on, and I will also ask Dr. Rosen-Carole if she has any comments about, how to address these myths. In terms of promoting intention to breastfeed, I think we can't just say to mothers, oh, it's natural, everybody, can do it. There are some women who get the baby, put it to the breast, and there's not a problem from day one. This is it is a learned skill, and the important part to think about is it's learning on the part of the mother and learning on the part of the baby. When we worked with the deaf mothers, they described it as a struggle or trying to get that, get coordinated so that, if you think about people who dance or ice skate together in pairs, they've got to coordinate this, the experience of breastfeeding. It's new for you, it's new for the baby, and it's something that's learned, but it's learned with support and information. The other things to consider is that setting a specific goal is important. A timed goal, so it's stated in days, weeks, or months, is much likelier to be achieved and represents a more significant commitment than just say, I'm going to breastfeed till he gets teeth, or as long as she wants. Those, when we've done studies, those have been as effective as not having a goal. So they aren't effective at all. The other part is identifying, who's going to be there for the mother during the postpartum period. So prenatally, who help her identify who are going to be her supports, her go-to people when she's is at home. And this could be people from on the resources in her among her friends and family. It could be resources that she's going to use like through a peer counselor or maybe at the hospital. But if it's somebody that's in her family that she's going to be turning to, or a friend, that person should actually know what the mother's goal is, and then that person becomes a partner in achieving that goal. And then from a home visitor standpoint, you can also be sure that person has the information or has access to the same breastfeeding resources, so they know where to turn when the mother is so frustrated she may have stopped thinking clearly about what her options are. And there are lots of resources available depending on the community, and I think it's important that you and your agency know what they are, and that certainly the WIC breastfeeding peer counselors are an important option that should be accessed, and connection can be made prenatally. Every WIC site is required in New York State to have a breastfeeding peer counselor. So I'm going to just continue on again. Anticipatory guidance before the birth. So this is stuff to just be certain the mother is thinking about, that she's getting care, that her provider knows what her goals are, and that she has the opportunity to talk with somebody else who's breastfed, maybe go to a support group or a class, identify what supplies she may need. And she can even, look at and see, so what's this latch thing about, and, become informed even before the baby is born. She could practice the various holds. There's a checklist that was developed and shared. It was developed, I think, out of the Vermont WIC folk. I've attached this here. I have it, I think it's on the next. Is it on the next slide? No. Okay, never mind. There is a checklist that's very that may be useful for you to think about. That I thought I had included a copy of that, maybe not. So many mothers focus on it during this time about getting a pump, and that's really only necessary for mothers who will be separated from their babies. And it's very easy to get too focused on the pump. Insurance companies will cover it. It does differ, from plan to plan. And mothers should learn to hand express, ideally in the hospital, but that sometimes doesn't happen. So you can talk to the mother about hand expressing during the prenatal period, but there's information on how to hand express in the guide to breastfeeding that I talked about. And it's also a way, and Dr. Rosen-Carole didn't mention it, that's, hand expression is also one of the ways to help manage minimize engorgement. Is there anything else that people have found to be important in this kind of thinking ahead period of time? Okay, not seeing any, we're just gonna move on. Other aspects of this prep is helping your client understand what can help in the hospital. Yeah. So this is what can help her get started on the right road to breastfeeding. And one of them is skin to skin after delivery. And by the way, if you haven't seen any of the baby crawl videos, I would encourage you to look on YouTube. They're really quite striking. And I actually think that showing mothers that, and this is the whole notion, is you put the baby on the belly, on the mother's, literally skin to skin, and the baby crawls up to the breast and starts to suckle. It is without prompting, without being pushed. It's just the baby smells the milk and moves toward the breast. They're really striking. But that's the whole point of skin to skin. And to begin breastfeeding as soon after delivery, there's lots of resources in the hospital, and to avoid some of the early triggers that may contribute to problematic breastfeeding, such as formula or sugar water, and avoiding pacifiers. And the moms may say, "Oh, I just want to put the baby in the nursery," but actually, mom and baby actually do sleep better if they're both in the same room. At night, it also allows the mother to breastfeed more often. And the notion that the initial milk, the colostrum that comes out, which doesn't look like breast milk, it looks like this, thick yellow stuff that we should be using as paste, but it is full of important nutrients, and it's jam-packed with nutrients because the baby's stomach, as Dr. Rosen-Carole mentioned, is not very big, and so that little bit that they get is a powerful punch in terms of nutrients. And by the way, there are some cultures that think that colostrum should be thrown away, that it's bad, but it actually is, it's referred to as liquid gold. And this is an example of the checklist. I just cut and pasted it, that's the link that was provided a couple of slides before, but it hits the key points of, during pregnancy, and then the preparing for the birth hits a lot of these same points about the hospital, and then thinking about who you're going to have at your helping you when you come home. Notice the first one is 2 people I can call and trust for helpful advice are. As I said, for understanding, and for you as a visitor to understand who those people are so they have good information. Okay, we're just going to walk through a few more pieces here and then open it up if there's other comments. So what new moms can do. So what is it that you can help the mother that you're working with think about? Well, creating a calm environment. And I know some of the mothers that you work with, their home or where they reside is like Grand Central Station. And maybe you would be able to likely observe that prenatally and then say to her, okay, so let's think about it when you're breastfeeding. Where would be the best place for you to breastfeed? How can you create, a less calm or an environment with a minimal amount of disruptions? Or what do you have to say to people to say, hey, I want to breastfeed. Can you kind of leave me alone for a little bit? And practice with the mother about how to manage that, because she may think, oh, I can just breastfeed anywhere. But in those first few weeks, and when you're really trying to get it started, you want to concentrate on your baby. And it's better if there's a way that you can create even a safe place. I've heard dads say, yes, I have to create a space. I have to protect my mom, my wife or my girlfriend or my baby's mother to, so she can breastfeed. So the dad may have a role in helping that, or somebody else in the family to create that environment. So we'll talk about the smoking. Somebody just asked about what happens if they're still smoking. We'll talk about that in a minute. They can still do skin to skin at home. It's nothing that's magical that ends when you leave the hospital, and other people can do it. And you heard Dr. Rosen-Carole talk about, calming the baby by doing skin to skin with what she called the non-nutritive caregiver, which means the person who's not breastfeeding. But that's just something that dads can do. The other is to not, grab the breast and try to stick it into the baby's mouth, and avoiding some of the artificial nipples until the latching has been well established. And as a reminder, this is the size of the stomach, so not much. So the cherry is a half of a teaspoon. that's not a tablespoon, that's a teaspoon. The day 3, you're talking about, an ounce or less. And week 1, you're only talking about 2 ounces at the most. So, and interestingly enough, early on, the baby's stomach actually doesn't expand. When we talk about the Thanksgiving dinner, yeah, we overeat because our stomachs will grow. Well, that stomach is not as flexible, early on, which is essentially why, babies will start, spitting up with that. But the other point is to follow the baby's lead, the feeding on demand piece. So other things that you can work with your mom on beyond the feeding on demand, again, the more the baby feeds, the more milk is made, not, because they're switching from this hormonally based to the supply demand based process. And they are hungry every few hours. They should actually not be sleeping through the night. Mothers see that as a great goal. I want to sleep through the night. Well, that actually does not help the baby from a nutritional standpoint. And then, if there's a concern about how much milk they're making, if they're got 6 wet diapers a day and about 3 stools a day, and these are typically kind of this seedy yellow loose stuff, that they're doing okay. So those are other metrics that the mother can do. And also, if we talk about what else the support person can do, which is provide other supportive care to the baby, being certain that the mother is taking care of herself, because boy, it's really easy to get lost in the shuffle, because not only, when you're pregnant, people are asking you all the time, how you doing? And all of a sudden this baby comes and the mother becomes this, secondary thought. And so the support person needs to make certain the mother's getting enough to drink and to rest, to do some problem solving, do some encouragement, play and cuddle with the baby. If you think about those cues that we talked about, the swinging, shushing, those things, that's certainly something that a support person can be doing. And also just be informed, like, what does a good latch really look like? And then lastly, how does a new mom kind of keep it going? Again, this whole issue of avoiding juice for the first 12 months and no water. Babies can get detrimentally affected if they're given water, even if that's used to stretch breast milk or to stretch formula. Don't smoke, drink alcohol, or use illicit drugs. So that's the ideal, is to not smoke. The reality is some mothers may have stopped during pregnancy and are starting up again. It's allowed to smoke, and I'm talking about tobacco, to smoke and still be breastfeeding. There's some guidance, about that, to not breastfeed, to wait for 2 hours after you smoke to breastfeed, to reduce the amount of nicotine and carcinogens that get transferred from the breast milk into the baby. But it's still, the AAP does recommend, because of the benefits in breastfeeding, that even if a mother's a smoker, she still should consider breastfeeding specifically. Now, the other question is, when you say, people ask about smoking, then there's, I don't smoke cigarettes. Because they're so bad, I smoke marijuana. So the active ingredient in marijuana, which is THC, does pass through the breast milk. We don't entirely know what the impact on the infant is, but there's so much variability in marijuana. Unlike, if you feed your kid formula, you can see on the back of the bottle what the ingredients are. Well, there's no such ingredient label on marijuana. And so what a mother is actually exposing her child to beyond the THC is uncertain. It's variable. And, I think that's an argument to stay away from marijuana. But I know that is an issue that many mothers are maybe using marijuana instead of smoking. So yes to tobacco, smoke, and breastfeeding, but other substances, including marijuana and illicit drugs, not recommended. And then other things is that even if, if the mother's sick, to stay breastfeeding, that, you can have, she can have sexual relationships while she's breastfeeding. You may need to make some modifications because sometimes the breast leaks. But again, birth control should be a priority if there's, if she's in a sexually active relationship. And then there's, and as well as keeping not only her prenatal visits or her postpartum visit, but the baby's visits as well. And I want to, if we go to the next slide, there's a little checklist here, similar to the one I showed before. And again, the link to that is at the bottom of the slide. Things about that list, how things are going well, and just some key points about, if you're not making enough milk, or and when to see the doctor. Whoops, that's good.
Yeah, it's on the picture.
Okay. So and then you talk about, the little answers about getting to know my baby and communicating with each other, talking to the childcare provider about supporting breastfeeding, talking to your employer. And WIC actually has some communications that mothers can use with their employers, some standard letters. In New York State, there are very few, between the New York State laws that are more stringent than the federal laws, there are very few employers who are exempt from providing accommodations or a site and time for breastfeeding. Some places are more challenging, but there are ways to provide support for that. So here are some resources that we put together. We will be adding, we'll be sending around some of the other ones that Dr. Rosen-Carole mentioned about specific items. But importantly, the Office of Women's Health is where a lot of this summary information was drawn from, has some nice pictures and language that's appropriate for our at-risk mothers. The health department has a variety of resources, including breastfeedingpartners.org. And then you can see there's several other resources. The WIC Peer Counselor Loving Support Program is another wonderful resource. So I'm going to stop talking. Sorry, I don't usually like to have too many talking. It says, if the mother is HIV positive, can she still breastfeed the baby? No. Not in New York State, not in the United States. If you're HIV positive, you cannot, you're precluded from breastfeeding. That is not how the rest of the world manages this problem. The WHO guidance is quite different. But at this point, it is not advised. Now, that doesn't mean that she may choose to breastfeed against medical advice, but it's still not, in the US, it's not considered to be the right thing to do. We may be modifying our guidance at some point, but for this change, it's going to be a while, I think. Great questions, by the way, and thank you. Give 8 points or special brownie points to all the people who are using the chat. The mother has hepatitis, can she still breastfeed? I am not sure of that, and I don't know if you mean like hepatitis. So and the advice may be different for the hepatitis A, B, and C. And I have to say I'm not specific. I don't know about that specifically. We can find out pretty easily. Other questions, comments? And again, my apologies, this was much more of a talking at you rather than with you, but there was a lot of information we wanted to be sure we shared. And just to note, you will see on those checklists, there's a list of resources. So it's a 2-pager, or it's a checklist that's got a front and a back. On the part that I didn't paste into the slide, there are a number of resources on those. Kelly Mom is one of them I remember seeing. And some of them are the same as what we've given you. Well, thank you all. We will be getting some more information out to you. The link to this will be also made available shortly. And thank you for your participation and your interest in supporting your moms to breastfeed, or your families to breastfeed. Thank you.